All right, let's go ahead and get started. Good afternoon, everyone, and good morning to those joining us from the West Coast. My name is Tamara Osmond, and on behalf of Muscular Dystrophy Canada, MDC, I'm very happy to welcome you to our webinar from our new Let's Talk NMD, Let's Talk Neuromuscular Disorder series. Before I introduce today's topic, I would like to mention that we have muted all participants, but I welcome you to type any questions or comments throughout today's session in the chat box. We have allotted time at the end of today's webinar for a live Q&A. Please note a recording of today's webinar will be made available on our MDC YouTube channel. With that said, let's get started. As many of you might know, August is Spinal Muscular Atrophy Awareness Month, and today's weekly webinar is on SMA and rehabilitation. Throughout the month of August, we have held webinars on what is SMA, what is the current state of treatment, current state of research, important issues related to adults living with SMA. And what we heard repeatedly is the importance of rehabilitation for infants, children, and adults with SMA, regardless of the type of SMA or treatment choice. And so we're very grateful for a terrific lineup of speakers that can help to share trusted and evidence-based information on rehabilitation in SMA. In advance of their presentations, I would like to thank each of our speakers for their time and expertise. First, we have Dr. Kathy Selby. Dr. Selby is a pediatric neurologist involved in acute and chronic clinical care, as well as academic and research commitments in neurological and neuromuscular disorders. Dr. Selby trained in St. Andrews and Manchester Universities in the UK and at University of British Columbia, and is the medical director of the Pediatric Neuromuscular Program, British Columbia and Yukon. Her main areas of specialists are pediatric neuromuscular disorders, including SMA and Duchenne muscular dystrophy, and she is involved with neurogenetics and knowledge translation. Dr. Selby plays an active role in medical education and was a former program director for the Pediatric Neurology Program at UBC. She is also actively involved with clinical trials in neuromuscular disorders and in patient advocacy. We're grateful to have Dr. Selby's ongoing support and for her time today to present on this topic. So I will turn it over to you, Dr. Selby. I believe we just need you unmuted. There we go.
So thank you very much for inviting me to be with you today, and I'm really happy to be with a lineup that, although there's a few of us from out here in the West, that we really have coast-to-coast involvement here with Scott from Halifax. So it's very exciting to be talking about SMA right now. We're really in a time which is very different from where it has been previously, where we are getting to understand both the underlying genetics, treatments, and learning more about rehabilitation. So I'd like to, the aim of the presentation today, I'll just go on to the next slide here, is really to look at the importance of multidisciplinary teamwork in SMA, to look at the values of the standards of care, to get physio and OT perspective on rehabilitation and outcomes in SMA, and to have Dr. Berger talking about rehabilitation supports for adults with SMA, and to have a brief view of future vision for management and treatment in SMA. Next slide, please. So here are my disclosures. I'm involved as the principal investigator in various trials for DMD and SMA. I've worked with Biogen and with Ionis on the National Advisory Consultant for Biogen and for Novartis. Any photos that are shown in my presentation are either in the public domain or have been consented by the family. Next slide, please. So as you all know, we're talking about 5Q spinal muscular atrophy, which is an inherited neuromuscular disorder that's due to a defect of the SMN1 gene. It has an incidence of about 1 in 10 to 11,000 and a carrier state of about 1 in 40 to 1 in 60 of us. It's a condition that causes degeneration of the motor neurons in the spinal cord and the brain stem, and there's progressive weakness and paralysis. And as you're all aware, the greatest majority of individuals who have SMA, about 60%, are actually individuals who have the most severe form, SMA type 1, and those are non-sitters. SMA type 2 is probably about 25%, and those are individuals who sit but don't walk. A smaller percentage are type 3s who are walkers, but they may lose the ability to do that over time. And type 4, those presenting in the adult world and at a much older age, and really a very small percentage, maybe 1 or 2%. Previously, there was never any potential for change of phenotypes, and that's really why that particular classification had been used. But as treatments are now becoming available, then there is evidence that one can change from one phenotype to another. And I suspect that we'll understand more that this is a continuum and will not be classified quite in the same way. Next slide, please. When we look here, we can see these bubbles sort of showing that that change between the two and how it's not a hard and fast rule, and it really is a continuum. Individuals who have the more severe form, who've been classified as type 1, will present before the age of 6 months. The type 2s or sitters tend to present between 6 and 18 months. The type 3s over the age of 18 months, and the type 4s, as we've mentioned, in adulthood. And the backup gene, the SMN, survival motor neuron 2 gene, is present in varying numbers. And again, there is really you can't classify it specifically according to the number of SMN2 copies, because as you can see, if you have 3 copies of SMN2, you may be a type 1, a type 2, a type 3, and occasionally even a type 4. One of our challenges, as you can see here, is from the symptom onset to the time of diagnosis can be many months to even years. And this is something that we want to try to prevent and stop, because we know that the sooner you treat from the time of diagnosis, the better. And better still is treating pre-symptomatically. So the question of newborn screening is something that we'll come back to later on. Go on to the next slide. So what's changed in the SMA? And I think that for really everyone here, that we can see that really everything's changed really very significantly over the last 5, 10, 15 years. There is a much greater awareness of the complexity of care. And back in 2007 and then again in 2018, there were standards of care written up showing a much better comprehensive approach, both in terms of diagnosis, rehabilitation, and other aspects of the care of patients with spinal muscular atrophy. And even before the last few years, when specific treatments have started to become available, the standards of care have made a very significant difference to the health and well-being and longevity of life of children and adults with SMA. Weakness has always been the key symptom. And one of the main challenges there, especially in the very young, has been breathing problems, both in terms of their ability to clear secretions, to be able to cough, to be able to swallow and have bulbar function, to feed properly, to speak, and then contractures of the feet, of hands, of elbows, and development of scoliosis. And the benefits of collaborating care showed that you could reduce admissions to hospital, reduce the number of times patients were coming to the emergency rooms, and there was the realization that these were able to improve quality of life and reduce the burden of care, and also the benefits of research and standardization of care. And when one started to look at outcomes, you were able to look at those things which could actually show meaningful changes. And really these were from everyday things, from stretches, from physio, from the things that parents do every day to clear secretions, and all of the basic cares that have really shown benefit in individuals with SMA. Obviously, one of the other things that has significantly changed that is the beginning of access to different treatments, which have really shown a very significant change, especially if treated very early in life. And next slide, please. It's quite incredible when you look back to the 1890s when the description of SMA was first made. And over those next 100 and odd years, there was really no change in anything that happened other than people describing beautifully, but describing the disorder and identifying that there were actually 3 different types of this disorder that all eventually became understood to have the same genetic mutation. And then realizing the abnormality in the SMN1 gene, and then the backup in the SMN2 gene, and then looking at those with scientists and geneticists, and realizing that you could start looking at RNA-based therapies and antisense oligonucleotides, and now looking at those treatments plus gene therapy. So really the root of the problem has become the root of the solution. And we'll go on to the next slide. And we can see on the next slide the pipeline of different treatments that are becoming available, that have gone from basic research into preclinical discovery, into clinical development, and now there are 3 drugs that have some form of approval through the FDA and are coming into Canada. So Spinraza is already here. Avexis is closely following that, and risdiplam just passed recently and approved by the FDA, which is also coming into Canada. So these are really exciting prospects to be added to standards of care to hopefully get the best outcome in individuals with SMA. And again, to be able to allow people to be very aware of this diagnosis so that the diagnosis can be made as early as possible, and also to consider newborn screening to be able to get the best out of treatments available. Next slide. And then we look at how multidisciplinary care is the way that has really developed how we can best manage individuals with complex neuromuscular disorders. And the aim is really to get coordinated care across multiple specialties and multiple disciplines, because we all have a lot of different qualities that we can bring to the table to understand what families and patients are going through as they go through this incredible journey with spinal muscular atrophy. Patients with the SMA have both weakness and the consequences of those weaknesses, and they have extramuscular manifestations. And the aim is really to allow those complex presentations to be addressed in one visit, and to try to reduce the stresses on scheduling so that one patient is being able to be seen by varying specialties and disciplines in fewer appointments. And when people have looked at this from a research perspective, it did seem to be preferable to uncoordinated care, and the quality of care and the quality of life were improved. Survival was improved, and there was reduction in acute hospital admissions as a result of being able to give multidisciplinary care. And this was looked at in both DMD and in ALS clinics. Next slide. We know that there's also been a significant evolution in healthcare, and the aims are to make this really patient-centered, to improve the quality of care, and to also look at outcome measures and look at goals and results from that care. As we've mentioned before, it is possible to reduce acute hospitalizations. It's possible to improve patient care, and also involve research, encourage advocacy, and involve support groups, which are incredibly important, both in support to each other and in allowing the specialists and other healthcare providers to understand the needs of those particular populations and to make sure that we can rise to that occasion. And as you know, there are very many individuals involved with each individual with SMA. Next slide. So the benefits of multidisciplinary care is that the team allows for this comprehensive approach, and the composition of the clinics may vary, and that may be at different clinics or across the country, or it may be within the same clinic at different time through a person's life and through a person's journey. And it allows the clinician to ensure that problems can be identified and dealt with by the right people or the right group of people at the right time. Weakness and fatigue are often the commonest symptoms that we see. And early on, as we've mentioned before, respiratory care and nutrition and growth are really the most important aspects of care. We want to be able to monitor bulbar function with swallowing, with speaking. We want to make sure there's adequate weight gain. We want to prevent aspiration or atelectasis with collapse of various parts of the lungs, as all of these will compromise the health and well-being of the child. And we want to involve physio, both from a respiratory perspective and from a general perspective. We want to involve the dietitian, and we also want to be able to involve occupational therapy, speech and language pathologists, and also to include splints or participation in life and other aspects that those individuals will help us so much with. When we look at the next slide, we can see just it's a very busy slide, and really it's just to show all the individuals that patients with SMA are needing over time and all the things that are happening over time. So that contractures are developing, a scoliosis may develop. We need to look after bone health, emotional health. They need equipment, need financial support. So there are respirologists and neurologists and orthopedic surgeons and geneticists, palliative care doctors, complex care doctors, GI, a feeding team, nutritionist, dietitian, dental team. Incredibly important to your family doctor, a pediatrician, psychologists, social workers, physios and OTs, nursing support. I've mentioned orthopedics twice because they are really incredibly important, and whether or not bracing needs to happen and whether or not that's helpful. So that these teams are very complex, but all necessary. And then there are some newer kids on the block that we've mentioned following on from treatments with Spinraza. So we are now involving more interventional radiologists and physiatrists to be able to help us as these children go into adult life. We're also involving anaesthetists more often, as some of our families where the children have been on Spinraza are needing more supports to be able to undergo that therapy. And then the use of feeding studies and sleep studies to make sure that we are working as a team to be able to allow the best health in that particular individual. Next slide, please. So the necessity and success of a multidisciplinary team really depends on communication and collaboration both within the team and also with community providers. And that can also be quite challenging and is something that is absolutely vital, because our patients are working on a regular basis within their families and within their communities, and will only see us in the multidisciplinary team once or twice a year. We want to be able to recognize changes that are occurring in the disease that require intervention, and we want to be able to initiate those, and we want to anticipate what's happening, and often the therapists within the community have a better idea of that than we do. We want to be able to prepare both the team plus the patient for what's happening with scoliosis or with transition to adulthood, which often parents will feel happens too soon after the child's just arrived in high school and suddenly they're being transitioned to adult care. Or to look at changes within ability and mobility, and to try to be proactive and preventative where possible. So vaccinations for RSV or flu shots, and then help with knowledge translation and with advocacy, so that access to treatments and newborn screening and other changes that are happening within the life of individuals with the SMA can happen in the best manner possible. Next slide, please. COVID has also been a very interesting challenge over the last 6 months, and many of our families have been unable to access the same care that they've been able to get before. It's put a significant burden on the families without being able to have access to the nursing care that they had before, without having access to the physiotherapists or occupational therapists, or being able to go to their swimming pool, or having interactions with other friends or family members. And so we really have learnt numerous things during this time, and we've had to look beyond the walls of our multidisciplinary clinics, looking at virtual clinics, at telehealth, at virtual assessments by therapists, at virtual therapy, and having virtual meetings, and even fundraising has been happening virtually. And there are ongoing educational needs, and some of these things that we've learned through this COVID time will also be helpful in the future. However, there is nothing better than being able to see patients, being able to have hands-on, and for the patients being able to access the physio, the different activities that they're usually involved with within the community. And all of these have really been significantly impacted during this time. Next slide, please. There are also significant importance looking at outcome measures of multidisciplinary care, and our therapists will go into this in a little bit more detail. I think firstly, the multidisciplinary care is associated with a better adherence to the standards of care, that we're able to be more efficient about resource utilization, reducing hospital admissions, reducing emergency visits, improving survival and quality of life. The challenge is in the consensus on what to measure and how that can be tracked. And registries such as the Canadian Neuromuscular Disease Registry has been very helpful in certain data sets to be able to do this, especially in SMA. And Muscular Dystrophy Canada has been very helpful with this. Next slide, please. I think that what is really challenging is not all meaningful outcomes are measurable, and not all measurable outcomes are meaningful. And this has been very clearly stated to me by some of my patients when they tell me I am so much more independent at school. And when I ask why, the things that I'm told are things like, I'm able to put my glasses on and off my face by myself. I'm able to keep my hands on the handlebars on my bike. I can play on Xbox. I can answer my phone. I can text a friend. I can scratch my nose without asking somebody to do that for me. I can play the keys on a grand piano rather than a digital piano, and I feel less fatigued. And these are all huge, and they are not well measured on some of the outcome measures that we use to be able to classify the benefits of certain treatments or therapies. Next slide, please. So when we're looking at outcome measures, they are incredibly important, but we have to find the right ones. We also need them when we're looking at this new world of innovative disease-modifying therapies, because with these very expensive treatments, we have to justify their benefits to the authorities that are paying for them. So within our ministries, we have to be measuring these outcomes at certain intervals, and we have to show the meaning and the value of these therapies in terms of these outcome measures. So identifying these are really important. And because of the different ages and severities of SMA, there are different standardized tests that are used in the different studies that have been used to kind of mirror the outcome, and these need to continue to be developed. So many of them you already know: the CHOP and 10, the Hammersmith, 6-minute walk test, upper limb modules, the MFM, but they are not sensitive enough, nor do they relate enough to everyday life. We also would like measurements on speech, on endurance, on swallowing abilities. And again, swallowing studies and respiratory function tests are useful some of the time, but again, do not measure everything. Patient-related outcome measures, which are unique to each individual patient, are important. And these are things that can be developed with your physios and OTs. Quality of life measures, measures of caregiver burden, and also prevention of loss of function. Next slide, please. When we look for the evidence of improvement in rehabilitation, there's an ongoing debate about the relationship between exercise and between neuromuscular conditions. And some studies recently have divided exercise into two groups. One is strength training, and the other is aerobic exercise, that is repetitive movements, such as swimming. Few studies have looked at both, and there's been a couple of studies. One was done back in about 2012, for over a 12-week period. They looked at strength training, and they showed that there was minimal change in strength. However, there was significant improvement in how the muscle could actually do the task, even though the strength wasn't significantly changed. In another study, where they were using a special exercise bike 2 to 4 times a week and measuring the VO2 max, they were able to show that this improves. So this is a measure of how muscles use oxygen. But again, there was no change in strength, but there was other measures of improvement with how the muscles were able to function. There's been no recent study on hydrotherapy, which has been very helpful in childhood, and no specific speech outcome measure, which again is really necessary, because this is certainly something that has been shown to improve as lung function improves, and is a really helpful measure and is vital to the health and well-being of individuals and the independence and autonomy of individuals. Next slide. So over the last few years, there's been a lot of excitement about the new clinical treatments in SMA. And there are now 3 that are approved by the FDA, 1 in Canada and the other 2 coming up close behind. And these are disease-modifying treatments that are really changing the approach of rehabilitation and care in SMA. Rehabilitation plays a much more important role than it used to, as this is now a treatable, although not yet a curable condition. Early treatment in both of these areas, both in terms of the new therapies as well as in rehabilitation, is really important to be able to get the maximum benefit. And educating families and therapists and physicians to be able to get the best evidence about what is best in each situation. Registries are really helpful, as these will be able to determine world-based evidence on what's actually happening to individuals. We would certainly like further trials to be able to look at some of these aspects, and this is something that we would hope to be able to achieve, although now that drugs are approved, this becomes more difficult. Newborn screening is really essential, and although at this point in Ontario, newborn screening is now a reality, in the rest of Canada, we would like that to happen as soon as possible, as treating early is going to offer our families the best outcome, and also to have an ongoing multidisciplinary approach. At the next slide, please. At this point, I would like to hand over to the rest of the team, and I'd like to just introduce them briefly. Angelina Wolf is a physiotherapist who works through BC Centre for Ability, who is the director of physiotherapy there, who's been very involved with studies here at BC Children's. Niamh Cushion is one of our other pediatric physiotherapists here at BC Children's Hospital, involved with our studies in SMA and other neuromuscular disorders. And Scott Thew is our representative from Eastern Canada, from IWK in Halifax, and who is involved as an occupational therapist working on assistive technology in a rehabilitation clinic, and is looking all at function. And this is what is so important with our neuromuscular families and with SMA, to be able to get the best outcome. So I would like to hand over to the rest of the team as they go through this next part of the talk.
Thanks, Dr. Selby. So we were tasked with answering the question, what are the rehabilitation supports and outcome measures available for individuals with SMA? This is a huge question, and in some ways, not one that we felt fit to answer. As rehab professionals, we know that interventions are the most effective when they're driven by the individual, and there's lots of research to back that up. Tools like the revised standards of care in SMA are available to help guide and inform decisions, but ultimately what rehab looks like, how it's delivered, and how we measure the outcomes of a rehab program will be unique to each individual. The top of this slide is an image from a campaign by Patient Voices in British Columbia. The aim is simple: encourage and support more meaningful conversations between people who provide health and social care and people, families, and carers who receive that care. It's a 3-step process. Ask what matters, listen to what matters, like really listen with your ears, your body, and your voice, and then do what matters by creating a partnership that embeds that information into the care plan, while still leaving room for that care plan to evolve when what matters to the person shifts or changes. In family and person-centered care, the role of the rehab professional is to act as a support to the individual and their family, and to offer suggestions that can be incorporated into their daily routines to help achieve their goals. Routine-based care is important to ensure that not just the goal is meaningful, but also how we work towards it is meaningful. We need to zoom out, look at the person's entire life, and then see how rehab fits in a way that is meaningful and considers all aspects of personhood. The three of us are coming at this from a pediatric perspective because we all work in pediatrics. We're trying to zoom out and look more holistically, but I think that disclosure is important. And if we can move to the next slide, I'm going to pass it on to Scott to talk about the ICF.
Thanks, Angie. So before we continue with our portion of the presentation, it's important to talk about the ICF, or the International Classification of Functioning and Disability, as the ICF informs our rehab approach. So the ICF is a framework that is used to organize function and disability. We often hear terms like function or improve function being used, but have we ever really considered what it actually really means? Because if we don't have a proper understanding of what function means, how are we able to effectively improve it? So one of the intents of the ICF is to mainstream the experience of living with a disability, and that having some level of disability is a universal reality for all. Because everyone at some point has limitations in different aspects of their lives. So when we look at this graphic, we have the health condition at the top, so SMA, and we have contextual factors at the bottom, so we have environmental and personal factors. It's the interaction between the health condition and the contextual factors that determines whether or not we experience function or disability within the different domains of our lives. So there's the body structure and function, activities, and participation. So we have function when we have a positive interaction between the health condition and the contextual factors, and we have disability when we have a negative interaction. So for example, we can have two people with the same diagnosis of SMA, so that's the health condition, and demonstrating extreme weakness, which impacts the body structure and function. But these two people can have two very different levels of functioning because of the context they each live in. For instance, if we consider the environmental factors and the limitations around funding, how each person accesses their services, whether it's private or public, may impact their level of functioning and can cause disability. This is like a big shift in the way we think, because it takes the emphasis away from the individual as the only contributor to function and disability. In our experience, we've never had an individual say, I need to be able to raise my shoulder 135 degrees. But we have heard, I want to be able to put on my sweater. I want to be able to pick up my child. I want to be able to drive. Families and clients tend to be more concerned around the activities and participation domains, right? So when we look back, this shows that there's been a disconnect with how rehab has traditionally been delivered, because rehab has usually been primarily focused on the body structures and function aspect, which is important. But it was always assumed that if we fix those areas in the body structure and function, it would automatically translate into improvement in the areas of activity and participation. We recognize now that in order to improve function, we need to address all areas of the framework. Next slide.
Thanks, Scott. Oh, I think we got to go back one more. They look very similar. Perfect. Thank you. Okay, so this is through a bit more of a pediatric lens. So in pediatrics, we use the 6 F words in childhood disability to build on the ICF framework, which is why it looks exactly, this slide looks very similar, just with different words in those boxes. And this is to help the ICF framework focus on all factors that are important to a child's development. Fitness looks at how a child stays physically fit and healthy and aligns with the body structure and function piece that Scott was talking about. Function looks at how a child does an activity, not how it looks or how it needs to be adapted. So what they're able to do, not how they're going to do it. Friends acknowledges that social interaction is an essential part of personhood and focuses on the child's participation with their peers. Family represents the essential environment of all children and highlights that a child's family knows them best. They should be asked, they should be heard, and they should be respected when planning a rehab program. And last but not least, future, which is along the bottom in that arrow, acknowledges that children grow up and that we should be planning for them to develop independence and be included in their community. You may have noticed that future was not included in that last ICF slide, and we would argue that considering the future is still an essential part of the rehab process for adults. How we look at the future for individuals with SMA and how that has changed with new therapies is going to impact the rehab goals that the person has, and consequently will impact the rehab process as a whole. Next slide, please.
So we've already talked about the ICF, and so now we need to think about the interdisciplinary approach and how we deliver rehab. In order to optimize functioning, we need to identify what's important to the individual. Where are they experiencing disability in their life, and what are their activity and participation limitations? Then we can make sure that the right supports are in place to achieve their desired goals. No one person is an expert in all these areas, so it's important to bring in the appropriate members when needed, so whether it's social work, psychology, dietitian, or rec, and so on, to address all the different domains of the ICF. If we don't recognize all the factors that contribute to function and disability, then we're not providing the best care. And as Angie mentioned, we have to be thinking about the future. Life is a journey, and on this journey we transition through different stages, from play to productivity, from work to retirement, or different roles, from being cared for to being a caregiver. More individuals with SMA are now able to think about the future while still managing their needs in the present. We need to think about having the right tools and right supports at the right time, which means that supports can address the current needs of an individual while considering the future. Wheelchairs would be a great example of this concept. When we focus on functional levels versus impairments, we use function-based goals such as to move independently versus lower extremity weakness. A common misconception is that by introducing a wheelchair to a child to address the present need, it means that we've given up on trying to walk in the future. The reality is that it doesn't mean that at all. The wheelchair achieves that present goal to move independently. But if we continue to work on and rehab working on walking, the wheelchair may not be the right tool for the future. And as Dr. Selby mentioned, it's a recognition that over time, needs change, people change, and circumstances change. So we have to have the right tools at the right time. Next slide.
Thanks, Scott. Hi, everyone. My name is Neve, and I'm a physiotherapist in BC Children's Hospital. I'm going to chat to you briefly about the importance of outcome measures in relation to SMA. This is a follow-on to what Dr. Selby has previously mentioned. Outcome measures need to be thought of in a similar vein to rehab. Not one method of measuring outcomes is enough on its own. Let's start with what an outcome measure is. Per the World Health Organization, it is a way of measuring change in the health of an individual, group of people, or population that is attributable to an intervention or series of interventions. There are many different outcome measures we use within the SMA population. This image, which is the ICF framework again, shows us how certain measures relate to the ICF framework. Some of these measures may sound familiar. This list is far from exhaustive, but it gives us an example of outcome measures used for certain categories. For example, when we talk about body structure and function, we can objectively measure range of motion and strength. Having these measurements can enable us to prescribe an individualized treatment plan and allow us to monitor response to the treatment into the future. When we discuss activity, we can use a measure like the Hammersmith, which assesses physical abilities via a number of varied tasks. For example, rolling, sitting, crawling, standing. When we look at participatory measures, we could use a tool like the CAPE, which is the Children's Assessment of Participation and Enjoyment. This is a self-reported measure of children's recreation and leisure activities outside of mandated school activities. Standardized outcome measures like these have an important role as they help us gather objective data to measure change pre and post interventions. This helps us understand what is working in a broader sense and in turn drive care and therapies nationally and internationally. It is important to be aware, however, as Dr. Selby said, that standardized outcome measures aren't always the most meaningful way of measuring function for clients and their families. However, being aware of the ICF framework allows us to choose the right outcome measures for an individual in combination with their own values. Next slide, please, Humira. So a big question to ask when identifying individual outcome measures is simply what matters to you. The iceberg is an easy image to help capture what we want to know. Standardized outcome measures, the tip of the iceberg, are an essential tool for measuring change and advocating for future therapy and services. But they are just that, the tip of the iceberg. Almost 90% of an iceberg lies below the waterline. The themes below the waterline represent what can be important for a client or their family. It is important for us as therapists to find ways to measure and track these client-centered goals, as they are what will help shape future interventions for those individuals. For example, a family may not register a 2-point increase in their child's CHOP and 10 score, but they are happy that they've managed to minimize hospital admissions with a respiratory flare-up, therefore reducing the impact on their family, school, and work lives. Another example could be of a young adult who may not be too concerned by a change in a standardized outcome measure score, but they likely will care that they have the vocal strength and quality to communicate effectively with their peers while playing Minecraft, or they can stay up gaming after a day at school without being excessively tired. Finding out what is important to an individual and their families helps us track outcomes that are meaningful to them. This, combined with standardized outcome measures, helps drive individualized care whilst understanding what is working in a broader sense. I think the next slide then is just our references. In summary, I hope that we've shown that both rehabilitation and how we measure change should be person and family centered and focus on all important facets of a person's life.
Excellent. Thank you so much. Next, we have Dr. Berger. Dr. Berger, I'll go ahead and stop sharing so you can upload your slides while I do your introduction. Dr. Berger is a clinician scientist in physical medicine and rehabilitation with a subspecialty training in electrodiagnosis and neuromuscular diseases. Dr. Berger draws inspiration for his research by observing his patient's journey through the rehabilitation process after spinal cord injuries and peripheral nerve injuries. Dr. Berger's research investigates the downstream effects of neurotrauma on the peripheral nervous system, including the neuromuscular nervous and autonomic nervous systems, using a combination of human neurophysiological and imaging measurement techniques.
Can you hear me?
We can hear you well, yes.
Okay, I'm just trying to load my files.
Great.
Hold on, I'm not sure. Because I sent you guys my slides. I thought you were going to do it. Hold on.
Can try to see if you have sent it over to us now.
I did. I emailed it to you yesterday. I can email it to you again because I'm not at my computer right now. That is the problem. But I can just email it to you right now. There we go. So I just emailed it to you. Are you able to upload them?
Yes, I'll go ahead and pull them. If you'd like to get started, if you would like
Thanks, sure. Yeah, I'll get started. My slides aren't, thank you for that lovely intro, and thank you everybody for inviting me today, especially Humira and Dr. Selby for putting my name forward. I'm a rehab medicine specialist, and we're also known as physiatrists or specialists in physical medicine and rehabilitation. And I understand that I'm speaking mostly with patients and families today, and it's totally fine if you've never heard of a physiatrist before, because most people, even medical students, haven't. But I'm here to convince you, or the big goal of my talk is to try and convince you that we're important within the multidisciplinary team of people that look after patients with neuromuscular diseases and especially spinal muscular atrophy. I'm a neuromuscular physiatrist and specifically an adult neuromuscular physiatrist. So while Dr. Selby has twisted my arm to see the odd pediatric patient in Victoria where I practice, I look after predominantly adults, so 18 and over. I think I can remember what the objectives of my talk are as Hamira is uploading the slide. I've specifically been asked today to talk about what rehabilitation resources are available or should be available for patients with SMA across Canada. And that's a pretty tough task for somebody that doesn't practice across Canada. But of course, I can give our listeners today some kind of basic framework about what resources are out there. I was also, oh, here we go, perfect. So the specific objectives, like I'm going to introduce what a physiatrist is. So that's point number one. I want to discuss before I get into what I was specifically asked to talk about, what are the secondary complications of SMA specific to adults that you may need a physiatrist for that are important to get kind of annual or semi-annual checkups for. And then we'll talk about what SMA rehabilitation resources are available. So we'll go to the next slide. So, what is a physiatrist or a specialist in physical medicine and rehabilitation? There's no exact definition. The three pictures that you see, the one on the left is a Kyle Lowry who just injured his ankle the other night playing basketball for the Toronto Raptors. So a lot of us do musculoskeletal medicine. And of course, musculoskeletal medicine is integral to spinal muscular atrophy. If you think about all of the potential musculoskeletal complications that can happen in SMA, and we'll touch on those a little bit later. Physiatrists are experts in looking after people with mobility impairments. So of course, SMA fits right in the wheelhouse of a physiatrist. And then few of us, mostly confined to the academic centers, are pediatric physiatrists. So physiatrists that have a year or more of extra training in looking after pediatric populations. If that's a bit too much for you, we'll actually go back just for 1 second. If that's a bit too much for you, what I usually tell patients is a physiatrist is somebody, if you think of an orthopedic surgeon marrying a neurologist and having a rheumatologist as a baby, you would get then their little sister would be a physiatrist. So it's kind of a mixture of those three specialties, or you can think about it as managing bone, joint, brain, spinal cord, nerve, muscle, tendon, and ligament. That's what we do. Okay, now we're ready for the next one. Why do I need a physiatrist if I have SMA? And we'll go on to the next one. Well, what can a physiatrist do? Well, this can work both for pediatric, but mostly for adults. So what a physiatrist does, if any of you are patients of Dr. Selby out there, you know that she's a phenomenal quarterback. So she really is the manager of the multidisciplinary team for patients with complex conditions like SMA. And a physiatrist doesn't just train in SMA, but basically every condition that a physiatrist looks after is complex. And so we spend our entire training learn how to manage complex patients within a multidisciplinary care setting. So one unique aspect of physiatry is that we train kind of hand in hand with the allied healthcare team. So I'm going to talk about who the members of the allied healthcare team are, but we spend our training kind of working with them. And physiatrists, we don't see ourselves as kind of the overseers or the overlords of the multidisciplinary team. We see ourselves as a cog in the wheel, but we are sometimes tasked with quarterbacking multidisciplinary care. A physiatrist can also manage secondary complications of reduced mobility, and we'll talk specifically about what some of those things are. Physiatrists are really important for device prescription. So a lot of times third-party insurance or even provincial insurance won't set you up with a new wheelchair or ankle foot orthoses or upper limb braces unless you have a prescription from a physiatrist. And a physiatrist works often with the technicians who are associated with fashioning those devices specifically for you in terms of optimizing for you. So working with the OT who does a seating assessment, or working with the OT who does upper limb bracing, or working with the orthotist who does lower limb bracing. So physiatrists can be involved there. One thing, the second last point there, one thing that I found in Canada and many of the centers in Canada is that there are a lot of amazing adult neuromuscular neurologists, but a lot of them are the scope of practice between pediatric and adult neuromuscular neurology is quite different. So Dr. Selby spends a lot of her time working with the multidisciplinary team, but sometimes the adult neuromuscular specialists are working in isolation. So they're on their own solo practice, or maybe with another one or two physicians, and they may not have the resources or even the kind of the framework to pull people together. And you can't manage a disease like SMA without multiple people on board. So sometimes the physiatrist will act as the de facto neurologist in centers where there's not a multidisciplinary neuromuscular service. And then the odd time you'll find a physiatrist like me who's kind of decided to streamline their practice to managing patients with neuromuscular diseases. And so here on Vancouver Island, I do prescribe disease modifying medication. So if there was an opportunity to prescribe some of the newer medications for SMA, then it would probably be somebody like me who's tasked with it. We can go to the next slide. So the secondary complications of SMA, and those are both at the pediatric and adult level. So what does a physiatrist do? And you can see on the right-hand side figure that multidisciplinary kind of framework for how to manage such a complex condition like SMA. That's stolen right out of the 2017 updated rehabilitation guidelines for SMA. So we do, what does a physiatrist do? We do bracing, we do wheelchair and other adaptive equipment prescription. We work on contracture prevention. So a contracture is just when you're not moving a muscle across a joint all that much, or if the muscle's too weak to move the joint through a range of motion, you can get really tight joint capsules and then the limbs don't move so freely. So that can be a real problem with helping people get dressed or helping position people in wheelchairs. If you have contracture, if you don't move so much, you can actually develop a lot of pain. So you can get a lot of patients that I see, especially adult SMA patients, get a lot of back pain and hip pain. So that is something that needs to be managed. Of course, physiatrists can help in exercise prescription, and that is related with nutrition and weight control. We can also identify deformities. And in the adult world, it's not uncommon that somebody has kind of been a walker with SMA3, but then over time they get less mobile. And sometimes their hips can pop at a joint, or they can get some curves in their back. So that's hip dysplasia and scoliosis. So a physiatrist is a good person to give you a once over every now and again to see if any of those conditions are developing. Physiatrists care a lot about speech and swallowing. Those are really integral body functions, and we work closely with speech language pathologists. And the topic of breathing function has popped up an awful lot already today. And so physiatrists are always attuned and will ask questions when you see them about how things are going at night and how exercise tolerance is going with respect to breathing. So we can go on to the next slide. Another thing that a physiatrist does, especially in the adult world, which is really important, especially adult patients with SMA who are well integrated in their communities. Well, things change over time, right? As you've heard in some of the talks already. And so physiatrists can advocate for vocational rehabilitation, so either a change in careers or adaptations within your current career. So a good example, I had a patient with SMA3 who was a forklift operator and was developing some weakness in their hands and was pretty much unable to drive the forklift over time. And so we had to think about modifying the patient's work environment to keep them happy and at work. So that's one thing that a physiatrist can do. Driving is really important, right? So sometimes if there's some ankle weakness or some trouble gripping the steering wheel, then driving adaptations can be made. Adaptive sports and leisure activities are really important. That can be guided by physiatry. Sometimes function changes over time to the point where home supports are needed. So help with basic activities like grooming or dressing or getting in and out of the bathtub. So a physiatrist can help arrange that. And never underestimate the importance of mood in healthcare. And many of the conditions that I see, including SMA, can be associated with depression and anxiety. So that's something that's really important to address at every visit. We'll go to the next slide. I was asked basically two questions. Are there any specific rehabilitation interventions that that we should be prescribing for SMA? And Dr. Selby already touched on some specific studies for exercise in SMA. And basically every time I see a patient with neuromuscular disease, they always ask me about exercise across the spectrum, whether it's a parent of a 2-year-old or an 80-year-old who is just diagnosed with inclusion body myositis. I am invariably asked that question. And the problem is I don't have an amazing answer for it, because despite this being a really important question and very fundamental and logical, of course, you want to exercise a weak muscle. We don't have a lot of spectacular evidence in neuromuscular disease one way or another. There's a few conditions like muscular dystrophy where we know that if you exercise really vigorously and try and, like, you know, bench press 200 pounds, you're probably going to do more harm than good. But exercise is always a good thing. It's good if you think about it from a top-down approach. It's amazing for your mood. It makes your body feel better. It gives you a rush of endorphins. And of course, there's some specific things for a condition like SMA where we need to exercise. But it's finding a balance. And I don't have an amazing way of telling patients where the line is or where you should draw the line. It has to come from within, guided by a physiotherapist or a kinesiologist. And it's always about kind of probing where the line is and trying not to cross over it and doing damage. That's the best that I can tell you, really. It's about maximizing function. Cardiovascular exercise and flexibility are supremely important. And although Dr. Selby presented you some of the literature already that's not amazing for cardiovascular exercise specific to SMA, it's still going to be really important. And of course, Dr. Selby touched on hydrotherapy, which is basically exercise in the water. I think that's what I recommend to all of my patients who have mobility impairments. Of course, the big issue now is how do we get into the water in COVID? And I don't have a great answer to that. I think especially in my adults that are aging with neuromuscular conditions like SMA, core strength and bum strength exercises are extremely important to maintain balance and to maintain mobility and to maintain function. And I don't know of any evidence that says core strength, meaning strengthening your tummy muscles. I don't know of any evidence saying that's a bad idea. So I wholeheartedly encourage it. I think you have to exercise in a supervised fashion. I don't think you have to exercise always supervised. So I don't think you need a physio or a personal trainer or kinesiologist always looking at you, but you certainly need your exercise program guided by an expert. And I think physiotherapy is really the best resource to use for exercise prescription. Please don't overdo it. So I know it's really tempting to try and build muscle strength, but we all have to remember that if a muscle does not have a nerve supply, it's really hard to make it bigger. And there's the potential of hurting your joints, tendons, and ligaments. And with respect to specific exercise prescription, it's really challenging because especially with the adult patients, there's a wide spectrum of abilities. So there's some patients that of course are wheelchair bound. Some patients are ambulatory, meaning that they walk around all the time. And some patients are even still running. So it really depends on kind of where you are. And that's why it's important to check in with a health professional like a physiatrist to get ongoing exercise prescription. I'll go to the next slide. So when I see an adult with spinal, like, why would you come and see me if you are an adult with spinal muscular atrophy? And so, what would you expect if you came to see me? Basically, every time I see you, which ideally would be once annually or once every 2 years, I would ask you the same questions every time. And the way that I frame my questions is the way that I frame my questions for basically any patient with mobility issues. And I ask you questions about what happens from the time that you wake up in the morning until the time that you are finished eating breakfast. And if you can do all of those things either on your own or with support, then you can pretty much take care of any challenge that comes across your day. So I start with, well, how do you sleep at night? How do you move in bed in the morning? How do you get from bed to the washroom to go to the bathroom? Can you get on and off the toilet? And so on and so on. So you see the progression of my questions. And then if a patient answers that they're having difficulty with any of those things, then that's where the opportunity to intervene is. So we can go to the next slide. My approach to adults with SMA is I recommend an annual physical examination to monitor for disease progression. I recommend getting a sleep study every 3 to 5 years because patients that have trouble with their diaphragm or trouble breathing because of weak respiratory muscles can often develop obstructive sleep apnea, meaning that you have trouble getting enough oxygen to your brain at night. And it sounds really severe. It's not that severe. It's typically not a life-threatening thing, but it can make you feel really crummy the next day if you're not getting a good night's sleep. It can give you a headache. It can make you feel like you're not thinking properly, and it can dramatically reduce your energy. So I recommend monitoring that very closely. I always recommend a swallowing study every 2 to 4 years to make sure that the food consistency that patients are eating is appropriate for them. I work closely with respirologists, but oftentimes I'm the one who's tasked with ordering pulmonary function tests or tests of how well your breathing muscles are working. I say every 2 years, but a respirologist may change that depending on who you are. Wheelchair needs to be updated every 5 years. So every 5 years, if you're using a wheelchair, whether it's a manual or a power chair, it needs to be refit because our bodies change. And so that needs to be typically prescribed by a neurologist or physiatrist and then performed by an occupational therapist. I always look out for overuse injuries, especially if we're still walking and we're getting a little bit weaker when we're walking. It can put a lot of strain on the back and the hips. That's no different than kind of, you know, your average adult person. As they get older, everybody in their life is going to experience about a back pain. And as we get weaker, the muscles in our hips start to get really sore and uncomfortable sometimes. So I can prescribe some specific interventions for that. Sometimes I even use injections like steroid injections into the back and the hip to manage those symptoms. And then we always need to plan for aging with spinal muscular atrophy and other neuromuscular conditions. And that means having discussions at every visit about, is your environment suitable for you? Is it still meeting your needs, or do we need to make any changes? We'll go to the next slide. I was asked about rehabilitation resources for adults with SMA, and this is a really tough question. I don't have an amazing answer for this one either, especially because there's going to be so much regional variation. And unfortunately in Canada, sometimes there's disparity. So some centers and some provinces are just better set up than others to provide resources. And, you know, in BC, my personal experience on Vancouver Island is I'm a bit frustrated about how difficult it is to get multidisciplinary care for patients with neuromuscular conditions, because they're uncommon and they're often not prioritized by health authorities. And so we're always kind of left with cobbling things together. And Dr. Selby spends a good deal of her time working with her team to work on how patients who are so well looked after when they're kids or in the pediatric setting, trying to maintain those services into adulthood. And it's really a challenge because once you become an adult, all of those multidisciplinary bells and whistles tend to disappear. So we do our best. There are lots of excellent resources, especially with respect to physiotherapy and occupational therapy, but sometimes they're only available privately. I think you will find that the resources are concentrated in academic centers or in big cities. And sometimes if you don't live in those places, it's hard to find resources. But every patient with SMA needs a multidisciplinary team behind them, and that can include OT or occupational therapy, PT or physiotherapy, SLP, which is speech language pathology, social work, could include a recreational therapist or a psychologist. So that's always my goal, is to cull all of those services together for patients with complex conditions like SMA. Most neurorehabilitation departments, so kind of most, you know, middle to large sized cities will have a neurorehabilitation department. They will have access to these services. So you need to go see somebody like a physiatrist or a neuromuscular neurologist, because they are the ones that are able to pull all of those resources together. Sometimes it's easy, sometimes it's not, but if you need it, they should be able to do it. This is one of the things that Dr. Selby has approached me about on numerous occasions is this idea of transitioning. So how do we continue services from the pediatric to the adult world? And so we don't have a phenomenal answer to that, but I think the earlier that you think about it, or the earlier that you are able to have these transition visits, to adult specialists, the sooner these things will be implemented, and then you won't there won't be a gap in care transitioning from pediatric to adult. I think that's it. That's all I have to say.
Dr.
Yeah,
Berger,
that's it.
Turn it over to Dr. Selby, who just has one final slide here in terms of the future vision for SMA. Just need to unmute. There we go.
Sorry about that. So yeah, I wanted really to finish off just putting some of these things together with what my future vision would be for SMA. And I think that we've heard similar themes throughout all the talks we've had this afternoon. So definitely comprehensive care in SMA clinics, to have an SMA center to evolve, to have access to treatments, to monitor rehabilitation, to look at outcome measures. That would be something I would love to see in the future. And to have multidisciplinary clinics in both pediatrics and adults with seamless transition. I would also love to see newborn screening in Canada nationwide, and to have recreational supports, to have access for all patients to research and education, access to patient advocacy groups. I'd love to see from a medical perspective that we can really get answers to the questions patients are always asking. I would like to see head-to-head studies of different therapies, to see combination therapy studies and to look at what benefits those might bring to patients, and to have patients, physicians, therapists, alongside pharma and government bodies all working together to continue to have this amazing vision of a hope for the future. I think we're at a time in SMA that is brighter than it has ever been before. There are still a lot of frustrations as we go through this time, but I think working together will give us the best outcome for the future. Thanks very much to everybody for listening.
Thank you so much, Dr. Selby. As you know, there was an opportunity to send in questions. I know we're over time, but I'll just briefly capture it. The information has been covered by the webinar, but a common question that we received was from adults with SMA, and they haven't seen a PT or an OT since they attended a children's clinic years ago. Is it common for adults with SMA to see PTs and OTs? And what we heard today is yes, and it is recommended. Dr. Berger, any comments for this individual?
Yeah, absolutely. So but it really is what often happens in the adult world, especially if people have been living independently and having a good quality of life for a long time, is they don't see anybody other than their family doctor. And their family doctors typically aren't even aware that specialist expertise is available for their type of condition. So I always have patients advocate to get them referred to a physiatrist or a neuromuscular neurologist to determine, kind of what allied services are needed or would be of benefit.
Excellent. And this is a very similar question again about seeing their neurologist every 2 years and what the recommendation is in terms of a multidisciplinary team. The next question here is from one of our clients who said, my daughter receives treatment for SMA, originally Spinraza and now Zolgensma. Are there benefits of the drugs if combined with exercise and rehabilitation? Dr. Selby, you were just speaking to this in that we need studies on combined treatments, but I guess in addition to that, to see also how rehabilitation supports combined therapies. Something else that was a common question that we've received is several families have opted to discontinue physical therapy in their home or going into clinics due to COVID-19. Dr. Selby, I believe you spoke about this in terms of virtual visits. Could one of the therapists also comment on whether that is an opportunity to continue to have access to PT services or OT services in your home?
Sure, this is Angie. I can comment and the others can jump in, but definitely we're using lots of virtual services in the community to be able to go into people's homes virtually, and then setting up an exercise program that can be carried out as part of their routine in their home, I think is optimal that someone has that anyway, has the home program in place, and then this is just one way to actually tailor it even more so to the person's own environment.
Excellent, thank you. Here's a question in terms of any tips on how to ensure community rehab specialists and hospital rehab specialists are on the same page or have similar goals for a person affected by SMA. Any tips on how a family or a person with can manage that?
Sure, I think I'll tackle that one. So, you know, what we often find in rare neuromuscular conditions is that the expertise lies in the academic center or is concentrated in the big cities. And that presents, especially in COVID, that presents an opportunity for community therapists to get some virtual direction from experts. And so the way that we're actually, so it used to be a limitation that if you were living rurally or remotely, you may not have access to the highest standard of care. But now we actually see this as an opportunity. And it is important for the patient to advocate for communication between community and academic therapy. But I think that is a stream of communication that's opening with COVID, and that's going to be really helpful for patients to get their treatment team on the same page.
Excellent. Thank you so much. So just being mindful of time, I'll go ahead and end today's webinar. I know there is this question around hydrotherapy, and Dr. Selby did mention that we have limited research on this topic, but I'd be happy to relay this to the panelists and share responses to the client that submitted it. But I would like to thank our speakers for sharing their insights and for their time in preparing today's presentation. I welcome you to email research@muscle.ca if we haven't attended to your questions or if you have other questions for our panelists. And I'd like to take this opportunity to also thank Roche and Biogen for helping to support education initiatives like this and for their ongoing collaboration. I will post top 5 key learnings from this webinar and a link to the recording by the end of the week. Thank you all again, and thank you for staying a little later than scheduled, but we appreciate that you have taken the time to learn more about SMA and rehabilitation. Thank you and have a great rest of your day.